Dear Chairman, dear colleagues, I shall start with this wonderful lady. You can find this merchant's wife here in St. Petersburg, in Mikhailovsky Palace of the Russian Museum. The lady doesn't look as a sick person, but can we imagine that the lady came to her general practitioner with heartburn? Every doctor will measure her waist circumference. Every doctor will measure her lipid and glucose levels, and every doctor will recommend her to restrict calorie intake and to use aerobic exercises. Why we're doing in such a manner? In the last century, it was proved that high BMI is connected with frequency of heartburn symptoms. It was a cross-sectional study in the Minnesota Olmsted County, and high BMI was the strongest risk factor for frequency of heartburn. More recent studies gave us the clear picture that obesity, high BMI, is connected not only with the frequency of reflux symptoms, but also with the frequency of erosive esophagitis. What is the mechanisms lying under the connection of obesity and GERD? It was proved that in high BMI there is a clear increase in the number of acid reflux episodes. There is increase in the number of long reflux episodes, and there is a higher percentage of time with lower pH. And in the recent study, it was clear that central adiposity is connected with high esophageal acid exposure, with more lower numbers of esophageal sphincter pressure, with lower abdominal loss length, and with some dysfunction of motility of esophagus. One can easily understand the mechanical cause of such problems in obese patients. Just high intra-abdominal pressure, hiatal hernia. But it is not the only mechanical causes of such association. Obesity is a problem that causes abnormal pro-inflammatory response in many tissues and organs. This response is mediated by pro-inflammatory cytokines and adipokines. Here you can see a recent study with very few persons that were very thoroughly investigated. But the message of the study is very clear. This is electron microscopy of the people with no central visceral obesity. Here the people with normal pH-3, and their intracellular spaces are normal. These are patients with GERD, with pathological reflux, and the diameter of intercellular spaces is greatly increased. And these are the patients with central obesity. And you can clearly understand that even when they have no problems on ambulatory 24 hours pH-metry, they have damaged structure of esophagus with great diameter of esophageal intracellular spaces. It is impossible to talk about obesity and GERD and not to talk about obesity and Barrett's esophagus and esophageal adenocarcinoma. We have a very clear meta-analysis. The strong side of this meta-analysis is that the patients were analyzed not only because of their BMI, but also because of their visceral obesity. And visceral obesity was greatly connected with erosive esophagitis. Visceral obesity, central adiposity, was greatly connected with Barrett's esophagus. And visceral obesity was greatly connected with esophageal adenocarcinoma. We can understand that if a person has severe erosive esophagitis, he will have more chance to get complicated GERD, to get intestinal metaplasia. But there are some other mechanisms lying under the connection of obesity and esophageal adenocarcinoma. This is a very nice epidemiological study. A great number of school children of Copenhagen have a register of their personal health. What is happening with these school children when they grew adult? According to Danish Cancer Registry, more than 250 persons develop esophageal adenocarcinoma. You can see here absolute male predominance. But what was important in this study? It was important that high BMI in the teenage period was a significant risk factor for esophageal adenocarcinoma. We do not know whether they have GERD, whether they have Barrett's esophagus, where they were obese when they were adult people. But the teenage visceral obesity was connected with a significant increase in risk of esophageal adenocarcinoma. According to genome-wide association study in Europe, there was found 32 SNPs that are connected with high BMI. And this column is very interesting. It is per allele change in BMI. If you have, for example, risk allele T, your BMI will be greater for 0.06. This study conducted using a special genetic risk score. There was calculated for each subject based on the total number of alleles, 0, 1, or 2, present for each of the BMI-associated SNPs. And it was analyzed for the patients of Barrett's esophagus, for the patients with esophageal adenocarcinoma, and with a control group of patients. Weighted GRS just revealed the contribution of each of the SNPs to the BMI. And the risk of esophageal adenocarcinoma was increased by 16% for Barrett esophagus and for 12% for and the risk of esophageal adenocarcinoma was increased by 16%, and a risk of Barrett esophagus was increased by 12%. Per 1 kilogram per square meter increase in BMI according to that genetic aspect. There are very interesting studies about GERD and different components of metabolic syndrome. This is a cross-sectional study with 100 consecutive patients. 54 have GERD and 46 were GERD-free patients. Frequency of metabolic syndrome according to different components, central adiposity, insulin resistance, high arterial pressure, was higher among patients with GERDs, but not in patients that have no GERD symptoms. There are several studies about GERD and the crucial component of metabolic syndrome, about insulin resistance. It was clearly showed in this study that the insulin resistance index was really associated with the frequency and severity of gastroesophageal reflux disease. Yesterday we have talked much about non-alcoholic fatty liver disease, and there are some works that connect non-alcoholic fatty liver disease as a disease in a metabolic syndrome in GERD patients. In a cross-sectional study, the presence of GERD symptoms was higher in non-alcoholic fatty liver disease patients than in control. And positive association was found between non-alcoholic fatty liver disease and the symptom of heartburn. What about aspirin? A great number of patients with metabolic syndrome use low-dose aspirin every day. And we all know that aspirin has a risk of gastroduodenal damage. And we all know that PPI therapy, as in this study was shown, help us to prevent gastric and duodenal erosions in aspirin users. What will happen to metabolic patient with GERD who will receive continuous low-dose aspirin therapy? In this study, there were 100 of patients that have at baseline Los Angeles grade A erosive esophagitis. Half of that patients received low-dose aspirin and placebo, and half of these patients received low-dose aspirin and esomeprazole. Those who receive placebo, in this group, the number of patients with erosive esophagitis increased greatly. And there were some patients with more severe grades of erosive esophagitis. Only in the group when esomeprazole was used, aspirin do not induce new erosions of esophagus. What can we how can we help our patients with metabolic syndrome that use aspirin? I think rebimapide is a very interesting agent in this situation. It was proved that rebimapide clearly protects gastric and duodenal mucosa in aspirin use and in use of clopidogrel, but it is very interesting that rebimapide can really protect the mucosa of small intestine when it is damaged by aspirin. And there was only one experimental study when acute reflux esophagitis in rats was prevented by rebimapide. I think it will be a very interesting field of new investigation. Weight loss is necessary in management of GERD patient. Weight loss reduces reflux symptoms in prospective observational studies. And in conclusion, it is necessary to consider GERD and Barrett's esophagus as frequent events in metabolic syndrome patients. The risk of esophageal adenocarcinoma is high in metabolic syndrome patients. Aerobic exercise and caloric reduction should be the key lifestyle modifications in metabolic syndrome patients with GERD. Thank you for your attention.